Our last talk this morning, before we get to the lunch break, is the biologic therapies for SLE, trials, troubles, and tribulations, and possible solutions. Dr. David Isenberg.
Again, David, thank you very much. I'd like to really expand on some of the themes that I was introducing to you in the first talk earlier this morning. Just have the lights down, please. So these are the pictures that I was showing you that were drawn over 150 years ago just to remind us how bad the skin rash can be in these patients. And I think this bit we've already covered. Just a few more pieces of information about the cohort that I have described to you, of these 500 patients, and to re-emphasize that the causes of death in the current patients are infection, which are undoubtedly related to the drugs that we're using, as well as vascular disease, and certain forms of cancer and active disease, including renal disease. And I want to emphasize with respect to renal disease that my strong belief is that the number one cause for renal failure and renal death in lupus patients is poor adherence to treatment. The number two cause, I think, is probably poor adherence. The number three cause is also probably poor adherence. And about fourth down the list is the severity of the renal disease. So it's really terribly important, if you're treating aggressive renal disease, to make sure patients are actually taking the treatment. And this data I've already told you. So this is to remind you just how aggressive these rashes can still be. You've seen those pictures from 150 years ago. Here are pictures of some pretty awful rashes on the bridge of the nose of this patient. Very nasty discoid rash over here, this patient on the cheek, and the vasculitis that we see in the toes of this particular patient. To remind you also that alopecia can be very nasty. It can involve the whole head in some patients, and it has gone on to do so in this particular patient. Renal involvement, again, just to emphasize, is mainly, I've updated the numbers here to the first 500 patients. We've seen renal involvement in 31% of the patients. And still we see diffuse proliferative change, membranous disease, and focal proliferative as a major problem. And as I've emphasized, 21 of our patients, in spite of our best efforts, have gone into renal failure. And of course, renal biopsy appearances are very variable. The type 1 is very mild disease over here. Here you'll see the diffuse proliferative change over here, focal proliferative diseases over there. And to remind you that some patients are unlucky enough to have proliferative disease as well as clots. And we see that particularly in this next patient. This patient has antiphospholipid syndrome complicating her systemic lupus. To remind you also that cerebral disease, we've heard a lot about that this morning, can be quite difficult to diagnose, and sometimes some of the investigations that we use are a little unsatisfactory. This was a patient who presented with severe depression. She didn't actually have antibodies to ribosomal P, but she was profoundly depressed. She had a strongly positive anti-nuclear antibody. The CT scan that was done initially was done on the right-hand side and effectively is normal. But when the MRI scan was done,